And I would just like to hand over this next segment to Karol. And Karol, I'll let you just frame what you're going to be talking about. Thank you.
Thank you very much, Jeanette and Helen. And actually, it segues quite nicely because we are going to be talking today, not an easy subject, it's neurobiology of trauma and post-traumatic stress. However, you know, this is very relevant to what Helen was talking about, especially, you know, in terms of the retention of stuff as well. So I've got a nifty presentation for you today. So let me just go into present mode. I should take about 20 minutes of your time. Few things to kind of before we start. Obviously this is not intended, but some of the information discussed here today some people may find that upsetting. Please look after yourself. You're not obliged to listen to the presentation, so take a break, breathe, ground yourself. You may, I've given different examples here of how you may do that. So look around the room, feel or stamp your feet on the floor. Think of your favorite holiday. Jeanette, okay, think of your favorite holiday or special place that we've just practiced. Splash some cold water on your face, etc., etc. I think it's fair to say that most of us have experienced some stressful or very stressful events in our lives. But please do not share your personal stories or experiences of trauma, especially in this sort of space, as this may trigger others. And also, I will make myself available after the presentation if there's something that has come up for you and you would like to discuss further. So what we're going to cover today, just very briefly, and this is going to be a very sort of whistle-stop tour of post-traumatic stress. So we're going to talk about neurobiology of stress, diagnosis of post-traumatic stress, as well as some treatment options and emotional regulation. In the next slide, there is a brain on it. So if you're feeling squeamish, please look away now. So before we start, I just wanted to tell you or share with you really my passion for post-traumatic stress, because it is something that affects our brain. Now, it is estimated that we have about 86 billion neurons, and neurons are obviously the nerve cells in our brain. So 86 billion neurons in our brain. Each and every one of them is capable of making up to 10,000 connections with other neurons around them. And there is a professor of neuroscience in Oxford. His name is Vilna Ramachandran, and he very famously said that there are more connections in the brain, in your brain, than there are known atoms in the universe. So just contemplate that. And by the way, this is an MRI scan of my own brain. So you are literally right now looking into my brain. And isn't it quite reassuring that there's something in there? So I wanted to start with some data that came out from the BBC survey that has been done in the first post our first lockdown. So we are already seeing that there is an increased adverse impact on mental health of our frontline staff, and we know it anecdotally, but also, you know, this survey kind of confirms this. So in the 1,194 UK frontline health and social care workers, 47% met criteria for anxiety as well as depression, and 22% met criteria for post-traumatic stress. Now, the usual prevalence of post-traumatic stress in general population is 8.6% in women, 4.1% in men. So women are more prone to develop post-traumatic stress, twice as much as men. Now, The current data from that survey, if you do some calculations, suggests that there's a 2.5 increase in PTSD symptoms in women and 5.3 in men at the moment. Well, or at the time of when that survey was done. So this is probably a bit of a flashback to your biology lessons. I hope that's not too traumatizing. But in terms of the stress and stress response, three main brain areas are involved with that. So that's hypothalamus, pituitary gland, and adrenal gland, and that is called the HPA axis. So the hypothalamus links the nervous system to the endocrine system via the pituitary gland. The hypothalamus is responsible for hunger, sleep, temperature, heart rate, as well as memory. And it stimulates the pituitary gland to release corticotropin, which stimulates then the adrenal cortex atop of our kidneys. And pituitary gland is responsible for stress, for growth, for reproduction, and for lactation. As this is happening, the adrenal gland releases the cortisol, which is our stress hormone, which initiates that stress response. And this is a very, very rapid activation of that fight, flight, or fight, flee response. But via the negative feedback loop, it suppresses the hypothalamic and pituitary hormones, so everything kind of downregulates by itself. However, the studies of post-traumatic stress have showed that there is either hypo or hyper-regulation of that HPA axis, so it doesn't work very, very well. What is also important to state here that we are wired biologically to respond to potentially threatening environmental cues, which activate that threat system. And it's a very rapid system. So if you imagine an example of walking down the street, you want to cross the street, all of a sudden you notice that a car is coming towards you. That system has to be very rapid, otherwise we know what's going to happen. I really like this quote. It's better to mistake a stick for a snake than a snake for a stick. And the efficacy of this system very much depends on that rapid activation, effective termination, and then adaptation following the onset of the stressor or the threat. So just to give you an example, so with the snake, what's that? It's a snake. There's that recognition activation. Oh no, it's a stick. Termination, I can calm down now, we adapt to it. And this made me laugh. Right, so we've got, in terms of the classification of diseases, we use two Bibles, or two books, shall we say. One is the ICD-11, the current version, which is published by WHO, and there's the DSM-5, which you probably have heard of, which is the American version. So the disorders that are specifically associated with stress, and they directly relate to exposure to stressful or traumatic event, or series of such events or adverse experiences, are post-traumatic stress, complex post-traumatic stress, prolonged grief disorder, adjustment disorder, reactive attachment, disinhibited social engagement disorder, and other disorders as well. But it's important to remember that post-traumatic stress, the stress is the key word here. So what's the difference between trauma and PTSD? Because very often you hear these kind of two words being used interchangeably. I particularly like the definition that comes from Lindemann in 1944 about psychological trauma, that the psychological trauma is a sudden, uncontrollable disruption of affiliative bonds. So I like to think about it that we all have a certain worldview. We all know how we operate in our worlds, in our ecosystem, shall we say. And psychological trauma happens when all those bonds that we created and those affiliations that we created, when they are severed very, very suddenly and uncontrollably. Now, post-traumatic stress is a difficulty or inability to recover from stress reactions to a traumatic event. So to kind of put it quite simply in terms of the hallmarks of trauma, and you will have to have all three of them in order for that to be to develop into post-traumatic stress. So first of all, hypervigilance. So what is hypervigilance? It's a vigilance towards potential threat and increased level of arousal as well. So as an example, you may experience some sleep difficulties, irritability, and concentration problems. Then we've got avoidance and numbing. So we avoid the situations of the stimuli that could reawaken the trauma. And for example, you may be avoiding certain news. You may not want to switch the TV on. You may even start numbing your feelings with substances such as drugs and alcohol or whatever, or food. You also may start withdrawing from others. And the third part of it is about intrusions. So this is about re-experiencing the traumatic event. Usually it comes in forms of flashbacks or nightmares. So some examples. So examples of traumatic events which you may experience or witness on a singular, repeated, or multiple times, which are associated with development of PTSD, are serious accidents, physical, sexual assault, abuse, including childhood or domestic abuse, work-related exposure to trauma, and that links directly to that BBC survey and post-traumatic stress of the frontline workers. And that includes also remote exposure, and I will come back to it in a second. Trauma may be also to do with serious health problems or certain childbirth experiences. It may develop during war and conflict, and I think the most often whenever we think about post-traumatic stress, we're thinking about the soldiers coming back from active duty, but also torture. So to develop PTSD, we have to be exposed to a traumatizing event or events. In normal circumstances, we cannot traumatize ourselves by the very act of our imagination without any prior exposure to trauma. So, for instance, going back to the including remote exposure. So we would have to have some form of underlying stressful or unresolved events that may link up to, for instance, hearing about something. So we may not necessarily be exposed to that directly, but we may be exposed to it indirectly, and it's called vicarious trauma. So sometimes, for instance, some therapists may develop vicarious trauma on the basis of just listening to a high volume, for instance, of traumatized clients, and that's why supervision and self-care is super important. So as an example, I just threw it there. Some people who may suffer from obsessive compulsive disorder may experience a lot of ego-dystonic thoughts or images, but they are fleeting, they are non-enduring, and they cannot produce symptoms associated with PTSD. I know that was a lot, so take a breath right now. Again, feel your feet on the ground, or whatever you're doing, maybe look around the room. And we will move on. Okay, so how is PTSD diagnosed? And the majority of the diagnosis in this country is going to be actually happening within the improving access to psychological therapies or IAPT services. They will use something called PCL, or in the past they used to use IESR, which is a very rapid kind of checklist looking at these different elements so re-experiencing, avoidance, and persistence perceptions of heightened current threat. So is that hypervigilance that I was talking about. There are certain thresholds, so it's not like you just tick one on every one of them, on every one of the questions, and that means that you have diagnosis. It's a it's a sort of a suggestive diagnosis. It's working with a formulation rather than necessarily diagnosing people. So this is about looking at whether these particular events that you've been through have had an impact on you. And the cutoff score for this PCL5 is 31 to 33. I wouldn't suggest self-diagnosing. So what do we do in terms of recommended treatment? So National Institute for Clinical Excellence suggests about typically 8 to 12 sessions of either trauma-focused CBT, that the PTSD which presented for more than 1 month after the traumatic event. So the 1 month is the cutoff place, because we may be exposed to traumatic events and not develop PTSD. And that period under 1 month is called watchful waiting. And those symptoms may resolve by themselves. Secondly, we offer something called EMDR, which stands for eye movement desensitization and reprocessing, which is like a specialist type of working with the trauma, but that is offered after 1 month to up to 3 months. And then again, EMDR is from 3 months onwards. For some people, this may not work, and trauma-focused computerized CBT may be appropriate. However, you know, the efficacy of it is well, it's better to see somebody, and it's better to kind of to work through it, either through trauma-focused CBT or EMDR. Important caveat here, I think, is to say that counseling is not recommended by NICE as a treatment for post-traumatic stress, unless the counselor has been trained in any of the above, so in cognitive trauma-focused CBT or EMDR. Now, there are some other modalities that work with trauma and work with trauma effectively, but they are not recommended by NICE. In terms of the pharmacology, generally it's better not to offer drug treatment unless it's necessary. Definitely not using benzodiazepines, because they interrupt memory formation. And some venlafaxine or SSRIs may be used for that, or in some severe cases, antipsychotic drugs may be used as well. So just to finish off, in terms of the emotional regulation, and you may want to use it or look at this for yourself. I've written out some really nice kind of and simple techniques that will help you ground. My personal favorite is the 5-4-3-2-1 technique, which is you think about if you have any kind of flashback, or if you have any kind of emotional disturbance, you may think about 5 things you can see, 4 things you can hear, 3 things you can touch and touch them, 2 things you can smell or like the smell of, and 1 slow, deep breath. You can add 1 more to the end of it, which is 1 nice thing about yourself. So that's it from me. Thank you very much for listening. I hope this was helpful, and yeah, I'll happily take some questions if there are any.